This is the April 7, 2023 Rheum Now podcast, and I'm Jack Cush with Rheum Now. Glad to have you here. This week, a lot of news. This week was the introduction hour of our campaign on women in rheumatology, the X Factor. I hope you've seen some of the content. We're really proud of it. I'm going to highlight it in many of the reports I'm going to review with you on this podcast. But first, let's talk about, I thought, a really interesting publication in JAMA that highlighted a recent AMA survey done in 2022 of prior authorizations and their effect. The bottom line is that 94% of physicians report significant delays in patient care associated with prior authorizations. That on average, this greatly affects patient care and how it's delivered in your office, with most physicians spending up to 2 days a week in efforts to acquire prior authorizations, with nearly 35% of all medical practices hiring additional staff to affect these prior authorizations. And that when you ask physicians, they would say the hassle of going through prior authorizations leads to 80% abandonment of the prescription you were trying to get authorization for. Again, why would you want to be a physician when you've got to jump through all these stupid hoops? The good news is that CMS and Medicaid, Medicare have realized that this is a significant problem, that they have proposed new rules that are currently open for public comment on how to speed up the prior authorization approval process. In this report that we've highlighted for you, there's also a call out to Congress, where there's a significant need for bipartisan effort to act on this problem, because it not only affects physicians and how they practice, but it clearly has a dramatic effect on patient care. It delays care. It leads to less than optimal care. Again, this is maybe one of the greatest headaches that medical practices have to deal with it. And doctors, not wanting to deal with these kind of headaches, usually end up having to pay for it, because they have to hire more people to do the work, to stay on the phone, to talk to a person who's got a third grade education, who's going to deny care. Honestly, this is just so stupid, it's unbelievable. But don't get me started. But you can get me started on novel new therapies for polymyalgia rheumatica. I saw an interesting pilot trial. It's a proof of concept trial using rituximab in PMR. Now, it wouldn't be my first thought from a biologic standpoint, like a mechanistic standpoint, but nonetheless, the BRIDGE PMR proof of concept study was a study of 47 patients who received a single infusion of rituximab. And the point was to see what would happen to them at certain time points. I think like week 21 was a main time point. But basically, after the infusion, they were followed for a year to see what would happen. And the bottom line was this was being used to see if it would lead to steroid sparing, and it clearly did. The percentage of patients who were in glucocorticoid-free remission at 12 months was greater within the rituximab group, 52%, than in those that were treated with placebo, 21%, and that was significant. There were no differences in side effects or adverse events or serious adverse events. Again, proof of concept, maybe this merits further consideration. Another early trial that we've reported on in the past, because it's been presented at the last few Congress meetings, is the use of emapalumab, a monoclonal antibody currently approved for HLH use, and it's a monoclonal antibody against gamma interferon. This is now the final report of it being used to treat macrophage activation syndrome in patients who have systemic JIA, most of those being kids, some of them being adults with stills. Nonetheless, in the 14 patients, the results are dramatic. These patients with systemic disease have MAS, a bad manifestation with a mortality rate up to 40%. So these patients are really a mess. But when you look at what happened to these patients, they're all on high-dose steroids. They all failed multiple other therapies. that there were dramatic reductions in all the markers of MAS, soluble IL-2 receptors, ferritin levels, CXCL9, which is a surrogate marker for gamma interferon. LDH drops dramatically. Steroid use drops dramatically. Again, the outcomes are highly impressive. That report is out there for you to use should you ever want to get this approved for one of your patients with MAS. Along these lines, treating systemic JIA patients or Still's patients are inflammasome inhibitors. These are in development. I put up a link to a number of usually small biotech companies who are developing these NLRP3 inhibitors, and there's a number of them there, and they're being used to treat different cancers, Parkinson's, osteoarthritis of the knee, gout, cryopyrin-associated periodic syndromes, CAPS, Schnitzler syndrome, just to mention a few. There's about 6 or 7 of them that are out there. Again, you've never heard of the companies because they're small. Usually these companies develop them in phase 1 and early phase 2, and if it looks promising, one of the big pharma companies usually will step up. I like this approach. I think it may have some promise for the future. An interesting study about depression and RA, something we don't pay attention to, and I'll say it right out. Right now, I think everyone that takes care of RA patients should be doing some sort of questionnaire or question about depression in your RA patients. I mean, we talked about it here before, that depression, when present, can not only lead to poorer outcomes, it leads to higher mortality rates. That was a report from, I think, last year's ACR meeting. With shocking data. Anyway, in this particular study, 182 adults with RA, and they screened for depression and anxiety. Half had depression, 25% had anxiety, and patients who had either or had higher HAQ scores and higher activity scores as measured by DASH-28. Depression, not surprisingly, was more prevalent in women, housewives, and lower educational groups. Surprisingly, anxiety was higher in blue-collar workers. Would not have guessed that. Again, we should be using a screening tool for this in routine daily practice. Another exciting report of new development. AbbVie did a press release this past week about a really novel therapy for patients with active lupus. Upadacitinib, a JAK inhibitor being used in lupus. A lot of JAK inhibitors have been tried in lupus. Baricitinib tried, did good in phase 2, did not do well in phase 3. Other JAK inhibitors are also in development. In this case, AbbVie's done a phase 2 trial in active lupus patients, and what they were looking to do here that was novel was test upadacitinib versus the combination of upadacitinib and a BTK inhibitor called elzabrutinib. When you put those two drugs together, AbbVie calls them ABBV-599. So this, again, early phase 2, met its primary endpoint of improving and showing a good SRI-4 response and reducing steroid doses to less than 10 milligrams a day. No new safety signals, kind of exciting. Again, the BTK inhibitor is sort of what's new here. We know that the reason why a JAK inhibitor might work in lupus is because of its inhibition of 12-23, IL-12 and IL-23. And with the BTK, there's a lot of B-cell effects. B-cell generation, immunoglobulins, but they also has effects on NF-kappa B and also on a number of chemokines. And so it's not surprising this combination looked good. Now, will it pan out to be better than a JAK inhibitor alone? We need to see more studies going forward. We put up a report this week about antiphospholipid antibodies and incident cardiovascular events. This comes from JAMA as well. This is a data where they had stored samples prospectively acquired in the Dallas Heart Study, and they looked for association between anticardiolipin antibodies on those plasma samples and future atherosclerotic cardiovascular events. Specifically, they're looking at first non-fatal MI, first non-fatal CVA, or death from cardiovascular disease. They tested for 8 different types of antiphospholipid antibodies and found that any one of them at any single time point was present in 14.5% of the sample. So these would be patients roughly around age 50 to 55. and looking for risk factors for future cardiovascular events. 1/3 of those patients had moderate or higher titers of those antibodies. It turns out that higher titers were actually more predictive of future events. Most of these were IgM, anticardiolipin antibodies. And then when you looked at actually the predictive value, the best predictive value was seen with IgA, anticardiolipin, with a 5-fold higher risk of future events, or beta-2 glycoprotein 1, that was IgA, again, a hazard ratio of about 3. Turns out if you had both of those, you had significantly higher risk. Again, these assays are not done in autoimmune patients. These are done in the general population about age 50, and looking for future associations. So yes, brand new cardiovascular event, you probably should be testing for antiphospholipid antibodies to see if that could be a potential causative factor. Interesting data. The EMA also came out with its final approval or update of its guideline regarding JAK inhibitors and the risk of major cardiovascular events, malignancy, and venous thromboembolic events. That is available on the EMA website. As you know, the main difference here is the wording that's different than the FDA warning here. The EMA update says that JAK inhibitors should only be used if no suitable alternatives are available for these patients over age 65, those who are current or past smokers, those who have risk factors for cardiovascular or malignancy, those who have risk factors for VTE should exercise caution if considering a JAK inhibitor. And the other thing that's new in here is they recommend periodic skin examination for all patients receiving JAKs, because one of the main cancers that were seen there was lung cancer, lymphoma, but also non-melanomatous skin cancer. So like the TNF inhibitors, routine annual skin checks are recommended in patients who are also taking JAK inhibitors. While all this data was generated as part of the oral surveillance study, which studied TNF inhibitors versus tofacitinib, these recommendations on JAK inhibitors per the EMA apply to not just tofacitinib, but also baricitinib, upadacitinib, filgotinib, and abrocitinib, the other one that's out there. So as you may have seen, if you looked at the website or the email this week, there's a focus on women in rheumatology. We've been wanting to do this campaign for some time, cover a lot of the news. We've got some really interesting blogs, I think one on advocacy, one on mentoring, that you really should look at. You should look at the Tuesday night rheumatology we did, which had to do with balancing work-life, or balancing basically family and career issues. I thought it was a tremendous, really informative, really interesting presentation of panelists done by Dr. Rachel Tate, Yvonne Shearer, Marcy, I forget the last name, and who's the other? Uma. Oh my goodness! Why am I blanking on this? I really strongly recommend you look at this. I now have to look it up because this is embarrassing that I don't remember it all off the top of my head. Nonetheless, I think this is a really strong 1-hour presentation that I thought was one of the best I've seen in a while. So Una Macris and Marcella Ferrata from the NIH. Shame on me. But you really should look at this or listen to this. It really was worth listening to. Some of the other things covered this past week in this campaign. A study from the DESIR early spondyloarthritis cohort, almost 500 patients followed for 6 years, showed that women in that cohort, half of them were women, half of them were men, had higher ASDAS-CRP scores, activity scores, and higher patient global assessments when compared to men. Even though men and women had similar CRPs and structural damage was more prevalent in men, activity is often much higher in the female cohort. Similarly, an analysis of almost 900 patients in the ankylosing spondylitis registry of Ireland showed that women had, at baseline, worse BASDAI scores and worse quality of life scores compared to men. And it turns out that actually those BASDAI scores, which are made up of 6 individual components, each component was actually worse in women than in men. Which goes to some of the reasons why treating SPA and PSA is sometimes harder with women. Another analysis that was published, I think, in J. Room looked at 3 pool data from 3 RCTs comparing tofacitinib to adalimumab and PSA in 800 patients. Baseline, women had higher tender joint counts, enthesitis scores, HAC-DI, and FACIT scores as well. Men had more dactylitis. Yet, when it came to outcomes in those trials, that there was an equal outcome as far as men and women, as far as ACR 20, 50, 70, PASI 75, etc. But women were less likely to achieve MDA responses with PSA. This has been seen in a number of different studies. So while some outcomes are the same, women tend to do worse in other, especially more superlative outcomes. A U.S. physician survey looked at the number of physicians who are out there and basically workforce analysis and who's working, how much, et cetera. So this study showed that the number of physicians grew significantly in the last 20 years, grew by almost 33%. Now there's 923,419 physicians in the United States per 2021. So while the number of physicians grew, the average weekly work hours declined almost 7%, going down from 53 hours to 49 hours by 2021. The decline was driven mostly by males, especially fathers, who had the greatest decline of 12% in work hours. Men are working less. Well, that's good for me as a man. Is also more apparent in those who were physicians in rural areas and a certain age group, 45 to 54. Turns out that the only group that had a significant increase in number of hours worked were, that's right, women. Theirs grew by 3%, and that was a significant growth over the last 20 years. The recent issue of Annals of Internal Medicine, or August 22 issue of Annals of Internal Medicine, looked at compensation levels between male and female physicians. Males were obviously outnumbering females in the workforce. But yet the number of women has grown significantly in the workforce, and even though the number of women being represented is far more in recent years, women primary care doctors earn on average $58,000 less than male primary care physicians. There is this issue of unequal pay that still exists, although the gap is closing. The question is the gap closing in other areas? An interesting study from the Leiden Early Arthritis Clinic showed over 15, almost 20 years ago, that the significant delays that existed in referral of early arthritis patients, RA patients, was greatest in women who had early arthritis symptoms. As much as 5 weeks difference between female and male patients. So they looked at the referral delays from 2005 to 2020, 15 years, and showed that the referral delay has gone down quite a bit. And that by 2020, the referral delay is the same between males and females. Females being seen, I think, 4.7 weeks, and males being seen 5.4 weeks after the onset of symptoms. So A, that's good news that there isn't this gender difference in referral of patients. B, it's still not that great. It still takes, on average, 5 weeks for patients to get referred to a rheumatologist. I want to give you a quote from Dr. Una Makris, one of my good friends and physicians at UT Southwestern, who I thought said a great thing during the Tuesday night rheumatology session on work-life balance that you can find on Room Now or on the podcast. She said, you can have it all. This was one of her mentors told her. You can have it all, but you just can't have it all at the same time or all at one time. There was a lot of very smart things said by Marcy and Yvonne and Una during this 1 hour session. The next session, going to be next Tuesday, is going to address contract negotiations. This one is going to be hosted by Gwen Melton and have guest speakers in Catherine Dow and a lawyer, Andrea Liberatore. Hopefully you'll find that a very interesting session. If it's anything like the last week's, it's going to be really interesting. Tune in by clicking on the link to register for the webinar, or you can actually watch it on YouTube, LinkedIn, Facebook, or on Twitter, where it's going to be live streamed. Hope you enjoyed this week's podcast. I did. We'll see you next week.